Good afternoon. I'm Bill Dietz. I'm the chair of the Redstone Global Center for Prevention and Wellness at the, at the Milken Institute School of Public Health at George Washington University. And it's my pleasure to moderate session 4, which is Models of Care Delivery for Improving Weight Management and Physical Activity. The reason we were able to concede 10 minutes to the last panel was that our third presenter, Susan Raffa, is ill and will not be able to attend today. But our first presentation is an overview of the models of care delivery and aligning programs with patient needs by Karen Basen-Engquist from the MD Anderson Cancer Center. The way we've arranged this session is to move from a more patient-focused perspective all the way out to the community and federal perspective. Karen?
All right, thanks very much. Welcome, everybody. It's good to see you here. I'm going to be talking a little bit about models of care delivery and just sort of thinking about how we align programs with patient needs and get patients to the programs. Oh, that green arrow. Okay. So as I was kind of thinking about what's needed in these kinds of programs, or what's needed to connect the cancer patients and the cancer survivors with the programs, I thought about our colleagues who do smoking cessation research. And so the area of smoking cessation is, I think, further along than we are, I think it's fair to say. But they've been promoting for quite some time a model called the 5 A's in primary care to get smoking cessation addressed, tobacco use cessation addressed in the primary care setting. And so the 5 A's are ask. So it's recommended that providers ask their patients if they're smoking. To advise them, to give them a clear, concise message that it would be better for their health if they quit smoking or quit using tobacco. To assess the readiness to change, basically, to assess whether the patient is willing to attempt to quit and what their timing on that might be. To assist them in doing that, providing some counseling, some tools, perhaps medication to help them with that, and to arrange for some follow-up. So checking in with them after the quit date to see if it was successful, to see what assistance could be provided. So I started kind of thinking, for the purposes of this talk, to think about what we know about connecting cancer patients and cancer survivors with weight management and exercise services to try to think about the extent to which this might fit for us and be useful. Now, I think we're much more of a puzzle than a straight line in our field right now. So I thought the puzzle pieces worked a little bit more. So in terms of ask and advise, so ask in terms of BMI, obviously we're way ahead, right? You know, if we always ask what we measure height and weight, we need to know that for chemotherapy. So that's a good thing. But the thing is, we don't necessarily do any advising after that with weight. And of course, it's pretty rare, even these days, for providers to be asking about how much exercise people are doing. So does this matter? So there have been some surveys that indicate that provider advice can support behavior change, like engaging in more physical activity. So this is a survey from the UK of over 15,000 cancer survivors that found that the survivors who recalled receiving some advice from their provider were more likely to be active and more likely to meet physical activity recommendations, as you can see in the orange and the green bars on the right. However, the problem was only about 31% recalled receiving such advice. So, even in the UK, I think they're more forward-thinking than we are about how they can incorporate this into care. We aren't seeing a lot of that. Kirsten, I'm glad you mentioned your study, if you're still here. Very nice study looking at whether providers are asking or advising. So as she mentioned, she did a chart review of clinical encounters with early stage prostate, breast, and colorectal cancer patients to look to see if it was documented in the medical record that, in this case, this was exercise, or physical activity, whether there'd been any recommendations made or inquiries. So she reviewed the records of 55 oncology providers, which totaled 361 encounters, and found that about 35% included some discussion of PA. It was really variable. You know, I think she mentioned the oncologists were more likely than some of the other types of providers, like the radiation oncologists, to have these discussions. Also, I thought this was a very interesting finding. It varied by patient age. So oncologists or the providers were more likely to discuss exercise with older survivors. And they were more likely to discuss it during the surveillance period or during endocrine therapy than in some of the other therapies. And these, I will say, these encounters were all selected to be times when it would be appropriate for somebody to be thinking about exercise. So these were not like immediate post-surgical visits or something like that. So it appears to be helpful to patients if their doctors talk about it, but they aren't getting a whole lot from their providers at this point. Another thing that needs to happen is the assess part. So I think when we're talking about physical activity and weight management, there's kind of two branches to the assessment piece. So there's thinking about somebody's physical condition and what kind of program, what kind of level of exercise might be appropriate for them. And I think that's where a lot of our thinking has gone. We've been thinking about kind of risk stratification and who needs to go into a structured program, who needs to go to rehab, who can do it on their own. And so that's kind of one aspect of it. But the other aspect that I think has been a little bit ignored is thinking about the patient's interests and experience with exercise. So not all patients are equal, even though we might feel that what the best thing for this patient is to be doing 150 minutes of moderate intensity aerobic exercise and 3 days of Katie Schmidt's strength training exercise a week as supervised by an appropriate person. That doesn't mean they want to do that. You know, it might be that the most that we can talk to this patient about that they're willing to think about is like just getting up off the couch and walking, doing a few laps around the house for a while. So, you know, the American College of Sports Medicine has recently revised its exercise screening recommendations for medical clearance. And I think it's relevant to this discussion for a couple of reasons. So one reason is it used to be that whenever we heard about, we're looking at advertisements for exercise equipment or joining a gym, what they would say is, consult your physician before starting any exercise program. But you notice you're not hearing that anymore. And the American College of Sports Medicine has kind of rolled back that a little bit and said, the things that we need to consider before starting an exercise program are whether the person's currently physically active, whether they have signs and symptoms of disease, and what the desired intensity level is. So I think it speaks to my point of it's important to think about what the person wants to do and whether medical clearance or a more supervised program is necessary for them. If all somebody wants to do is do some light intensity, moderate intensity walking, they might not need clearance. And why is that an issue? I mean, obviously it's a good thing if you go to your physician and they say you're healthy enough to exercise, that's okay, but that can be intimidating to some people. If that poses a barrier to being more physically active, we don't want to do that unnecessarily. So we've been kind of thinking about this both for exercise and weight management, a group of us, and we've been thinking about this for cancer patients and survivors as sort of a matrix. And if you look at the horizontal matrix, if you look at the vertical matrix, vertical axis of the matrix, it's really kind of the risk stratification, right? You've got patients towards the bottom who are pretty healthy, not a lot of comorbid conditions, well-managed, minimal treatment side effects, up to patients and survivors who are, are maybe have very involved cancer-related symptoms or side effects, or patients who have some pretty severe comorbidities. So that's our kind of risk stratification as far as the patient or the survivor goes. And then there's also the risk level of the activity that they want to do. So in the case of exercise, it might range all the way from reducing sedentary behavior and doing some light activity to kind of more vigorous intensity aerobic exercise, strength training, which might be risky for some individuals if they are at lymphedema risk, and then other kinds of things like high intensity interval training that we know less about as far as its safety. And so if you're down in the kind of lower left-hand part of the matrix, it's the more community, home-based, less supervised approaches that might be most appropriate. But as you go up in risk in the upper right, you're thinking more about those more supervised and maybe even medically supervised programs. Now, we tend to think about it more with exercise and think about risk more with the exercise realm than weight management, but we also need to think a little bit about weight management programs. And, there can, obviously, we have kind of a patient risk stratification here from, patients who have a normal BMI up to patients with very severe obesity, but also thinking about patients who have cachexia and sarcopenia and what kind of dietary approaches might be healthiest for them. And also, what kind of activities are they interested in? Are they interested in just general nutrition and being healthier? Or are they interested in, losing weight as fast as they can? What's going to be safe for them? And then, of course, and I'm sure a lot of you who do weight management or dietitians in hospitals or in cancer centers, hear from patients who have a lot of ideas or seen a lot of things on the internet about some other interesting diets that may or may not be evidence-based, and of course, that patients need more guidance about. So moving on to the kind of what in the smoking, in the 5As is the assist and arrange arrows. I think, it seems that the consensus in oncology is that oncologists and oncology care providers are probably not going to be the ones actually providing exercise services or providing weight management services, it's probably going to be more of a referral mechanism. And so in order to refer, you have to have something to refer to. And that is, there are a lot of different kinds of intervention settings that, and you're going to hear some examples of programs from those different settings in a few minutes. So thinking about home-based, community-based, and clinic-based is sort of one way to break them down. In reality, there's a lot of overlap there, and a lot of things are kind of hybrids, but I think it's a useful way to think about it because these settings tend to differ according to whether they're likely to receive insurance reimbursement, whether they are medically supervised, and so forth. So, thinking about the home-based, you've already heard some great examples of these programs, things like Wendy DeMark-Wanifried's Renew program. They could include print materials and tailored print materials, videos, smartphone apps and wearables, social media interventions, and telephone and video conference coaching. These are things that are being researched and studied, but there's also quite a bit of evidence emerging that these approaches can be effective. Community-based programs tend to be more face-to-face types of programs. Examples include the Live Strong at the YMCA. Weight Watchers is an example of a community-based program that's not cancer-specific, but has been used by some cancer researchers to study weight loss in cancer settings. So the community is another kind of locus for some of these programs, and especially for people who prefer a more face-to-face approach, this can be helpful. One example that we have done in the Houston area is sort of a hybrid between the home-based and the community program called Active Living After Cancer. This was based on a small trial that we did of a lifestyle intervention that was for breast cancer survivors specifically at that point. But we gathered survivors together 16 times over 6 months and taught them behavioral skills for making changes to increase physical activity in their life, also addressed some survivorship issues. The focus was really on short bouts of moderate intensity activity, so this is not a very intense program, but it was targeted at very sedentary survivors. So we had significant benefits on physical aspects of quality of life and also on physical functioning as measured by the 6-minute walk. We later received state funding from CPRIT, the Cancer Prevention Research Institute of Texas, to disseminate this in the Houston community. So we are now in the process. In fact, we just found out that we got 3 more years of funding, and we're taking it to El Paso too. So that'll be fun. But we're seeing similar good effects in the community dissemination of the program. The participants significantly increase their physical activity and improve their physical functioning. But the challenge for us always is still getting the patients, into the program. How do we inform people about the program? How do we get them to come? How do we get them to stay? So it's not just about having a program to provide, but really how do you drive the traffic to your program? So that referral piece, you know, and indeed many of these people are referred by their healthcare system, but it doesn't mean that they're all getting there. Clinic-based programs we'll also hear a few examples of, but I think, you know, the advantage of some of these programs is they do provide sort of optimal levels of medical supervision for people who need that. They are more, at least in terms of the rehab programs, there is some reimbursement tied to it. As mentioned earlier, the dietetics programs in cancer settings do not tend to be reimbursed by insurance, so that is a barrier to kind of broader implementation. But nutrition programs in other kinds of practices might be reimbursed. So, for example, in cardiology or diabetes care. So to the extent that cancer survivors have other comorbidities, they may still be able to get some counseling from a dietitian that's covered. And of course, medical weight loss programs may be appropriate for some survivors. So some issues and some considerations that we are still dealing with in terms of having programs to refer to. One is program quality and reliability. So especially given that there's such a diversity of types of programs and approaches that could be appropriate for a survivor, how does a particular oncology provider know where to refer their patient, especially in a place like a tertiary cancer center where they might be having patients come from a very broad geographic area. Also, the question, and it was raised earlier, about do we need cancer-specific programs? So I think this is something that we really haven't investigated sufficiently. Excuse me. Although a few investigators have used some community programs, thank you. So a few investigators have used some community programs in their research and found good results, but we don't really know if that's who that's effective for and when. It's likely that it may depend a lot on the health condition of the survivor, but also the risk level of the activity and what the person's actual comfort level is. Thank you so much. Some survivors, even though they're in very good health, still don't have a lot of confidence about their ability to exercise, and they don't know what they should be eating, and so they may feel like, they really need a cancer-specific program. So given the problem that we have sort of with the referral link here and really getting people out to the programs, I'd like us to kind of think for a minute about taking a more active role in that, or a more active approach to the referral piece. So, and this again, I'm going to bring in a couple lessons from the smoking cessation field. And this is from a study done by Dr. Jenny Vadrine, who's a former colleague of mine and now is in Oklahoma. But she randomized 10 safety net primary care clinics to two approaches to getting people to the tobacco quit line. One is ask, advise, refer. So the patients are asked if they're smoking, advised to quit smoking, and asked if they're willing to take a referral card to the tobacco quit line. And 5 clinics were randomized to that. They identified over 10,000 smokers that way. They gave a referral card to 3,698. That's how many agreed to take the referral card. 56 of those called the quit line. So that's pretty dismal. So that's where referral gets you. 53 of them did go on to receive the quit line treatment, but that's only about 0.5% of the smokers they originally identified. Ask, Advise, Connect is a little bit different because instead of just giving somebody a referral card, they say, can we give your name to the tobacco quit line? And if the person says yes, then the tobacco quit line contacts the smoker and tries to see to assess whether they're interested in starting treatment. So in those clinics, they identified over 7,000 smokers. They had over almost 3,000 who agreed to be connected to the quit line. 1,700 actually talked to the quit line. And of those who talked to the quit line, just over 1,000 received treatment. So again, one lesson is you got to be a little more active than just handing somebody a referral. The other lesson, I think, is, I think we could all agree that we'd love to see more than 15% of the smokers get to quit-line treatment. And we'd love to see more than 15% of our survivors get the appropriate physical activity and weight management services they need. So there's still a lot to learn, but it's probably going to take a little bit more than just handing somebody a referral. So putting these pieces together, I think one of the things that is really needed in this field, we've talked about some of the gaps in evidence, we've talked about the evidence is there, but one of the things that we need to think about is kind of the dissemination and implementation piece. What are the models that we could use, and that we could maybe take a look at what's happened in smoking cessation and what's happened in the diabetes area and so forth, to think about how we put these into practice and connect patients with the programs and study some of those models of implementation and dissemination. In the screening area, we need to think not just about patient risk stratification, but also what the patient interests and experiences are, and make it a very patient-focused experience rather than just this is what we think you should do. We need to learn from others who have gone before, like I said, the smoking cessation researchers, the primary care researchers, and think about more active models than referral only. And finally, we need to move towards better and more consistent standards for a variety of programs so that oncologists can be comfortable and confident in referring or connecting people with specific programs. So thank you.